for those of you that are here in person and those of you in the ether. I'd like to introduce Dr. Paxton Bach today, but before I do that, a land acknowledgement. So we're acknowledged that we're working and playing on the traditional, ancestral, and unceded and occupied homelands of the Coast Salish people. Today's Grand Round, you can see the title. I think it's pretty exciting for those of us in acute care. So I'm looking forward to the presentation. So Dr. Bach.
Yeah, I'll try. Thanks, Dr. Casson. And thank you for the opportunity to be here. I'm very, very happy to be here today talking about a project that has been really 4 years in the making at this point. So it's really exciting to have this see the light of day. Before I begin, I'll just ask that anyone from any other sites who are tuning in, be sure that your microphones are muted. Hopefully we've got our technical issues sorted. So I'm going to be talking about the 2023 BC Opioid Use Disorder Guidelines, providing a general overview of the guidelines themselves, as well as trying to focus in on some implications that I think have unique relevance to clinical care. As Dr. Casson has already done, I would like to just acknowledge we're calling in from the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I feel very privileged to live and work in these lands, and I'm very thankful for the stewardship. My disclosure, so I do have research funding from Michael Smith as well as CHR and related topics to these guidelines, but nothing, but no direct conflicts of interest with the guidelines themselves. I am one of the co-chairs of the guidelines, so I was one of those who invested a lot of blood, sweat, and tears over the past few years on this. I will make that disclosure. These are the goals for today. This is what I like to cover. So I'm going to talk about the guidelines themselves, review the process and sort of the content of the guidelines as a whole, discuss a little bit, unpack a little bit of the key updates and key changes from our old guidelines and talk a little about some of the evidence that has informed those changes. And then again, I think of particular relevance to this crowd, I'm going to talk a little bit about exploring specific changes that I think have relevance to our work in acute care hospitals, recognizing not everyone calling in maybe works in acute care hospitals. So hopefully there's something here for everyone. So just by way of background, this is the 2017 opioid use disorder guideline that was put out by the BC Centre on Substance Use back in 2017. This was the first ever clinical guideline that was put forward by the BC CSU, and I think was a real landmark document for the province. And I just want to spend a second reflecting on kind of what this document meant. It was the first comprehensive provincial guideline in Canada around the treatment of opioid use disorder. There was a number of really key messages contained within this guideline that I think have really shaped the care of patients with opioid use disorder over the past 6 years. As I mentioned, this was the first ever provincial OUD guideline, comprehensive guideline in Canada. It had a few key recommendations that were some of them less novel than others, but really I think important lines to draw in the sand, specifically recommending against withdrawal management alone for the treatment of opioid use disorder, which is there's very strong evidence to suggest that can increase somebody's risk of overdose and overdose death. It really clearly positioned buprenorphine, also known as Suboxone, as our first-line treatment agent for the treatment of opioid use disorder in our province. It added slow-release oral morphine, also known as Cadian, to the menu of options for the treatment of opioid use disorder. And this was really new. Cadian has been used in Europe for many years, but had never been used in North America before. Many of you who've come into this work since 2017 have probably just seen it and accepted that it's around, but this was actually had never before been used in North America prior to 2017. So that was a really key addition. And it really emphasized the importance of harm reduction counseling at every stage of an interaction with somebody who uses opioids or who has a diagnosis of opioid use disorder. So there's obviously much more content, but those are a few of the key items that I think really leapt out of this document and have really informed clinical care since its launch in 2017. There was really direct, visible consequence or visible implications of this guideline. This is the number of opioid agonist treatment prescribers in our province from 2015 to 2024. You can see that the line at the top there that ends in just over 2,000. That is the number of prescribers we have in our province who are certified or approved or registered as prescribers of opioid agonist therapy. You can see, I don't want to put all of the credit on this inflection point on the guidelines themselves. There's a lot of action happening around that time and since then, but you can see a very clear inflection point around 2016, 2017 in the number of people who are actively prescribing these medications in our province. For many years, we were around that 400 or 500 level, and it's now over 2,000 people. So that's a 400% increase since 2017, which is, again, not purely attributable to the guidelines, but a lot of work that has been done since then. And I think is really a testament to a lot of the education that we're trying to do in the province and that we do in this hospital. You can look at the number of people who are actually accessing opioid agonist treatment as another metric. And you can see that number back in 2015 was around 15,000 people, which had been fluctuating but somewhat steady for years. And you can see another real increase around that same time. Obviously, this overlaps with other changes, including the overdose crisis, which we'll talk about plenty today. But you can see that number's up to just shy of 25,000 now. So a significant increase in people who are actually currently at this moment enrolled in agonist therapy in our province, which I think, again, is a testament to a lot of hard work by a lot of clinicians out there.
Paxton, what's the denominator for both the physicians and the people?
Physicians is a good question. How many physicians are in the province of BC? I actually don't know. As far as people who would be candidates for opioid agonist treatment, that's a hard number we can guess. Obviously, we can do some modeling and try and look at what we know about prevalence of opioid use disorder. It's probably somewhere around 100, 120,000 people in the province who would meet criteria for an opioid use disorder. That's based on kind of statistics from elsewhere and some modeling done by a group at SFU. So maybe 20% of the people in the province who would be eligible for opioid agonist treatment are currently enrolled. There's more to the story than that. I'll get to that. I don't want to celebrate this too much, though, because while it's laudable to see, I think, these increasing numbers and increasing interest in prescribing these medications, increasing number of people accessing these medications, we are very clearly not winning. So this is not news to anyone here, but this is the number of overdose deaths in our province over the past 2 decades. And you can see that very significant uptick around 2015, public health emergency declared in 2016. Every year, almost with only one exception, every year has been worse than the one before it since then. So while I'm very proud of seeing more people out there trying to prescribe these medications and doing this work, it's clearly insufficient. And so I think that really informs a lot of what drove these new guidelines. I'll point out, again, not news to anyone, that there's been a significant change in the drug supply since these last guidelines came out. Fentanyl, this is drug types relevant to death as per the BC coroner. 90%-ish of overdose deaths in our province now involve fentanyl or primarily attributable to fentanyl. So not only is there still work to be done in terms of ensuring that we reach more people who don't have access to these medications, but obviously the game has changed somewhat since fentanyl has arrived on the scene. I think it's important to remember, so as devastating as the arrival of fentanyl has been, and all of the other components of a evolving drug supply, this is a paper that I think about a lot, and I'll put it out there to everyone, because as discouraged as we can be trying to practice in this environment and prevent these overdose deaths, this is a paper put out by Bodan Nosek out at SFU that suggests that, as difficult a time as we're having, that opioid agonist treatment is still effective. This is still a life-saving treatment, even in the context of fentanyl. I think that's important to remember. So this is looking at standardized mortality ratios over about a decade between people with opioid use disorder who are on treatment with opioid agonist treatment, whether that's buprenorphine or methadone or Orcadian, versus off of it. And you can see that the yellow line is those who are off OAT, a relatively high standardized mortality ratio with a significant increase around 2015. Just to put that in perspective, a standardized mortality ratio of 10 to 12 is absurd. That's insane. That's unbelievable. That their likelihood of dying is 12 times higher than an age-matched individual. But you can see that those who are on treatment with agonist therapy, their SMR doesn't really change over time, suggesting that if we can get people on treatment, this can still be really effective. It can still be very helpful at preventing overdose death or all-cause mortality. It's just a question of how do we do that? And that's really, I think, where again, what informed a lot of this work, because the corollary to that paper, another paper by the same group, also shows that over 2 decades, from 1996 to 2017, at the end of follow-up, the amount of people with a diagnosed opioid use disorder who retained on opioid agonist treatment for a year or longer was 16%. So we have incredible treatment with 60 years of evidence supporting its efficacy at preventing overdose death. We have good reason to believe it can still be effective in the current context, and we can't keep people on it. So that is the fundamental question, I think, informed a lot of the changes in our new guidelines, is how do we do better at actually increasing retention on this treatment? Why are people discontinuing, and what can we do about that? So the 2023 update goals were really to align the opioid use disorder guideline with practice changes that have been evolving over time in our province and elsewhere, and to review new evidence, and there has been a considerable amount of new evidence since 2017, and incorporate that into the clinical guidance as appropriate. The process is rather traditional. It's a little dry. So we had a provincial committee established. So there's 3 co-chairs. Somebody there? Okay. We had 3 co-chairs on the committee, myself, Rupi Brar, who's a physician in the Downtown East Side you may be familiar with, and Emma Garrett, who's a registered nurse. We had an interdisciplinary committee from around the province of physicians, pharmacists, people with lived experience, who all contributed to the guideline. We had 3 specific working groups that were established, focusing on some key clinical questions, which we'll unpack a little bit, and a pretty expansive external review process with expert reviewers from across BC, Ontario, and the United States reviewing the final product, as well as the College of Physicians and Surgeons, the College of Pharmacists, and the College of Nurses for the province, all of whom reviewed the document as well. It was developed and it was informed by the Agree-To tool, as clinical guidelines often are. There was structured literature search involved with a specialist engaged in helping with that process. Recommendations were evaluated using the GRADE framework. So it was really conducted according to a pretty traditional, pretty rigorous guideline development process. There's lots of new content. This is about 220 pages. Much of it is iterative. Much of it are small changes or expansions on certain topics. These are some of the highlights that I will point out as notable to this guideline compared to the 2017 one. Additional of more expansion on principles of care, some key clinical guidance changes, inclusion of some new treatment options, expansion on continuing care, longitudinal care for people with opioid use disorder, and many new appendices, including one about emergency department initiation of buprenorphine. I'm going to focus on these 3 things today: key changes to clinical guidance, inclusion of some new options, and this specific appendix is, I think, the ones that may be of particular interest to this group. So the key changes to clinical guidance I'm going to highlight are largely focused on outpatient settings. They will have less relevance, I think, to those who are either working in an inpatient setting or who don't directly do this kind of prescribing themselves, but I'll still highlight them a little bit because I think that it's important to understand where these are coming from. So and I'll review each of these really quickly and then kind of go into more detail. We talked about selection of OAT as something that was really important. So the 2017 guidelines, as I mentioned, established buprenorphine as our first-line treatment for opioid use disorder, sort of essentially followed by methadone as sort of it's not officially labeled a second-line treatment, but kind of an alternate first-line treatment. And slow-release oral morphine, which was the new addition in 2017, was restricted to specialist-led prescribing. With increasing familiarity with these medications and a recognition of the differences in the idiosyncrasies that each of these have, the 2023 guideline really is eliminating that idea of a hierarchy and really focusing on highlighting the difference between these medications and working collaboratively with an individual to find the one that meets their needs and preferences as quickly as possible. Dosing and titration, the 2017 guideline contained what I've said here are conservative starting doses and titrations. In 2017, they weren't. They were traditional, I guess I would say. We were dosing this according to 20 years of standard practice. And there's a very conservative dosing strategy for medications like methadone, recognizing that if you start a medication too fast, it can kill somebody. So we are quite conservative and thoughtful about the way we start those, but it's very clear in the current climate that people who are tolerant to fentanyl are a different beast. There's different needs. The tolerance that we're seeing in hospital, as many of you probably have noticed on CTU, is just different than it used to be. And so there's a recognition that, especially for fentanyl tolerant individuals, different dosing and titration strategies are needed. Similarly, missed doses have traditionally, for 20 or more years, been treated rather conservatively. Methadone specifically has an unpredictable pharmacokinetics. There's lots of genetic variability, and so when people miss multiple doses of methadone, we recommend dose reductions to ensure that there's no lost tolerance and that we can safely proceed with prescribing without putting them at danger. And we've taken quite a broad look at the breadth of missed dose protocols across North America, and revised those recommendations somewhat based on what other jurisdictions are doing. And lastly, and maybe most notably, some really key changes to take-home dosing. Methadone, as you're all aware, is daily witnessed. Slow-release oral morphine, daily witnessed. The vast majority of dispensations in our province are daily witnessed, and thanks to some really interesting data that came out of the pandemic, we've taken a new look at take-home dosing protocols and revised those somewhat in concert with our colleagues in Ontario. So I'll go into each one of these in a little bit more detail. So again, as I mentioned, OAT selection, this is actually a significant change because it eliminated that idea of hierarchy of these medications and just recognized that these medications are different and they have different characteristics, and it's important to find the medication that suits an individual as soon as possible if we actually want to retain them on treatment. That is not so the goal here in removing that idea of first and second and third line is not to equate these medications in terms of efficacy or safety. And we unpack what we know about the efficacy of safety of these individual medications separately. But it emphasizes that finding an effective medication quickly and collaboratively is really the key. I would highlight that the quality of evidence and strength of recommendation for methadone and buprenorphine, which have been used for 60 years and more than 20 years respectively, high quality of evidence, very strong recommendation. Slow release oral morphine, much newer, at least in North America, still a strong recommendation, but an acknowledgement that the strength of evidence behind slow release oral morphine is less than the other two agents. As far as dosing and titration goes, I've mentioned we have traditionally started these medications somewhere between 5 to 30 milligrams. I should say methadone between 5 to 30 milligrams, depending on somebody's presumed tolerance and their use patterns. 30 milligrams a day of methadone is a fine starting dose if your therapeutic range is going to be 80 or 90 or 100, which is sort of a traditional therapeutic range. We recognize that in the current climate, we're seeing patients who are needing double that in order to achieve a level of stability. So we've increased the starting dose here to up to 40 milligrams per day in those who are fentanyl tolerant, who have a demonstrated tolerance to fentanyl. That is an incremental difference. I will acknowledge that. If you're looking at somebody where you expect their therapeutic dose is going to be 150 milligrams and you're going to be doing serial increases by 10 milligrams at a time to get up there, this is still going to take some time. Many of our patients who were involved in reviewing this still found that this was inadequate. We are handcuffed by the fact that there is zero literature out there on starting doses any higher than 40 milligrams anywhere in the world. So I will point out that I still feel this is not where we need to be, and we need to develop more precision in our ability to titrate these medications. You will all be aware that in hospital, when we have increased resources, we can do that. But in the community, we have at least recommended starting doses as much as 40 milligrams and a slightly increased titration schedule to try and get people to a therapeutic dose faster. It is incremental, but it is a significant change. Similarly, we've done something in parallel with slow release oral morphine, where 200 milligrams is sort of the usual starting dose in the province for people who are fentanyl tolerant. And it's recognized that for people who have that documented fentanyl tolerance, a starting dose of at least 300 milligrams is felt to be quite safe. And again, therapeutic doses for this is often north of 1,000 milligrams. So there's been a small adjustment, but still I think a meaningful one in terms of trying to get people to a stable dose faster. This recognizes the higher opioid needs for people who are fentanyl tolerant, and it's based on some references in the literature for doses as high as 40 milligrams, but most importantly aligns with clinical experience in our province since fentanyl has entered our drug supply. And the goal here is to get people to a therapeutic dose faster. According to traditional titration schemes, it could take up to 3 months to get somebody to a therapeutic dose, which is a lifetime if they're still accessing an unregulated drug supply every single day throughout that time. Missed dose protocols, as I mentioned, this is an interesting one because if people miss more than 2 or 3 doses of methadone, historically we've reduced their dose to account for the possibility of lost tolerance and the risk that it might put them at. It is. I don't want to sound cavalier in underestimating the potential risk of methadone and our need to ensure that we are operating safely and not putting people at harm. But it is very clear from our patients this is an enormous barrier to retention. If people miss 2 doses of methadone, or historically, or 3 doses of methadone, they're getting a dose reduction. If their pharmacies close for a long weekend and they don't manage to come up with a plan to get the medication over that long weekend, their entire treatment plan can be derailed. And so this is we're told so often how much of a barrier this can be. And actually looking at this has been kind of the standard in a province for quite some time. And looking at the literature behind this is actually very interesting because there's an enormous variability of recommendations around North America and not one shred of evidence to actually inform any of them. They've all just sort of been settled on in their respective jurisdictions, and we've kind of operated that way for a long time. So we've taken a look at what they do in the US, what they do in Ontario, other provinces, and adjusted this somewhat to allow or permit up to 3 missed doses of methadone or slow release oral morphine before dose reductions are enacted, which again is small, but a very considerable difference for those who are called out of town or get sick or any number of reasons why you might miss a couple doses of medications if you have to go to the pharmacy every day to get those. This is recognizing the significant impact of missed dose reductions on both safety and retention and care, balanced with that very real risk of OAT toxicity that I don't want to minimize. And it aligns with methadone guidance in Ontario specifically, as well as with some jurisdictions in the United States. Again, those wide variations in practice, really, really interesting. And this has become a very, I think, an area of research interest for me that I think is really important. The goal here just to not disrupt treatment. Yeah.
Do those apply if setting up missed doses or using?
Yes. So historically, there's no, there's a lot we could talk about here. So methadone and slow release oral morphine both are different medications. Methadone specifically is the ones that we're most concerned about because methadone is the one with the most unpredictable pharmacokinetic profile, and it's also a medication that's metabolized through inducible enzymes. Lots of changes when you're starting on it, when you're stopping on it, when you're interrupted. So whether or not you're still actively using those pharmacokinetic changes are still happening. So historically, it has not mattered whether you're using or not. If you miss those doses, there's concern around your metabolism methadone, your risk of causing harm. Slow release oral morphine, we kind of operate along similar principles, but it's actually pharmacokinetically quite a different medication. So that has always been historically the way that we've operated. There is a recognition in these guidelines that that's probably an important thing to take into account, but how to take that into account safely, we don't actually know. So I would not recommend to anyone that they necessarily go outside of these and continue them on for people who've missed more doses than that automatically. I just don't think we have the data to recommend that safely, but there is a recognition of prescriber discretion here and context, right? In hospitals, a very different context from the community where you can actually see somebody every day. So there is some discretion recommended, but it's hard to give parameters for that without any actual data to inform it. And the harms of being too aggressive can be very significant. So lastly, those first ones have less relevance, I think, to this acute care setting, but they are they're small, they're iterative, but collectively very significant, I hope, in terms of what it is like to be on these medications in our province. This last one has a little bit more relevance for us in hospital, and I think is probably one of the most significant changes in these guidelines, and that's a review of how we provide people with take-home doses. So some of you may be familiar that previously in BC and in most of Canada, in order to take home doses of these medications, in order to not have to present to the pharmacy every single day of the week, you had to be on a stable dose for at least 3 months with no missed doses and no signs of any other substance use, which is reasonable for some and not reasonable for others, and quite a high bar to set. I think you'd agree. Like that's a very, very carefully regulated medication. That is like nothing else we prescribe in North America. And there's good reason to be careful and thoughtful with methadone. This is a medication that one can very easily harm somebody with, that somebody can very easily accidentally overdose or increase the risk of overdosing on. It is not something to minimize. But those bars are very high. Now, a very interesting thing happened in the context of COVID-19, where decades of recommendations along those lines in Canada and the US suddenly kind of all went out the window as we were desperately trying to keep people at home. How do you keep people at home on methadone? Well, you don't make them come to the pharmacy every day to take their medication. So there was a very sudden relaxation of a lot of these protocols through most of North America, where people were suddenly being given lots of take-home doses to try and keep them at home for the purposes of self-isolation. So this is a really interesting natural experiment because that is a very clear breakpoint. That has never been the case before anywhere in North America, and suddenly that was the uptake of those guidelines was very variable, but there was a lot of latitude provided all of a sudden in almost every North American jurisdiction. And so a ton of research was done on what were the outcomes for that. Now, this is all, it's important to recognize that this is all short term, right? Like this has not been very long, but there's been a ton of publications through the US and Canada. I'm highlighting this one by Noah, a colleague of mine in New York, just because it's a nice, relatively recent systematic review that included, this was limited to US studies, but there's 29 studies on the outcome of that change just since that change was made in 2019. So a ton of emphasis around this question. Patients expressed in qualitative work that take-home doses supported their treatment experience and autonomy. Not surprising. Providers expressed that flexibility allowed for more patient-centered care. That was a common theme in qualitative work. In quantitative work, no significant increase in methadone overdoses was observed in any setting. Modest improvements in retention were noticed sometimes intermittently. There were concerns expressed by some physicians around potential disruption in routine and decreased contact and the implications that might have. But overall, the results have demonstrated by and large, a much improved experience for patients and providers with similar, if not better, outcomes in terms of treatment retention. That's the US context. This is a paper by Tara Gomes. Some of you may know Tara. She's an epidemiologist in Toronto who does really good work in the space, looking at the implications of such a policy change in Ontario. So this is taken directly from their conclusions. During the COVID-19 pandemic, dispensing of increased take-home doses of opioid agonist therapy was significantly associated with lower rates of treatment interruption and discontinuation among some subsets of people receiving OAT, and no significant increase in opioid-related overdoses over 6 months in a follow-up. Recognize this is observational. This is very possibly susceptible to residual compounding and many other issues. So they should be interpreted cautiously. But by and large, over the short term, we suddenly have reams of data across North America that maybe we're being a bit too restrictive with these medications, considering, again, that incredibly poor retention we have at 1 year. So this has been the revision that's been made. And so this was done in very close collaboration with a group called Medify Ontario. So Medify is the Ontario organization who kind of sets their clinical guidance, much like we do in British Columbia. And so these are identical guidelines now that have been launched in Ontario and in British Columbia around take-home doses, where those who are not able to store their medication safely, or have significant physical or mental illnesses, or high risk uncontrolled substance use, still may not qualify for take-home dosing. But once you have been established on a dose for 4 weeks and there's some level of stability, you have an ability to store your medication safely, and you have clinical and psychosocial stability such that you reliably take your medication at the discretion of the physician, people can begin to start taking non-consecutive take-home doses home. And after a period of 12 weeks, which was historically the threshold for accessing any take-home dose at all, as long as you're consistently taking your medication and that clinical and psychosocial stability is improving, you can begin to take home non-consecutive doses. And you will note that abstinence from substances is not a criteria anywhere here, which is a massive change. Uncontrolled substance use that might put you at a risk of the ability to safely store your medication certainly is, but somebody who uses some substances intermittently and is felt by the clinician to still be able to faithfully take the medication and be safe with it, there's much more of a clinical discretion incorporated. So this is a dramatic change, a dramatic relaxation in access to take-home doses, which I think was going to have really significant impact on the quality of life and hopefully retention for our methadone patients. It's a big change, and I'll acknowledge that. But I think if you were not putting this in context of the old way we were doing it, you would still look at this and say this is remarkably regulated. It's just we're so used to having it be almost unachievable for certain segments of the population that this feels like a dramatic difference. But it very much is. Really, again, the goal here is balancing those benefits of earlier take-home doses with legitimate concerns around individual and public safety, but it's grounded in a substantial amount of research that's been done in the context of COVID-19, albeit not a long follow-up, and aligns very carefully with what's being done in Medify Ontario. So the goal is just to reduce barriers to retention and care. Again, really addressing why are people dropping out of care and what can we do to address that. For those who are interested, these are the Medify documents. They put out a really thorough review of the evidence in this area and really expanding a lot of these guidelines in these Medify materials. So those are the key changes to clinical guidance that I wanted to highlight, because I think those are some of the more meaningful ones, and I think they do have some relevance to us in hospital. less so, given that we have different resources in hospital. We're not necessarily totally bound by all the same rules in community prescribing. But the pieces that I really want to highlight today as ones that I think have a lot more implications for us in hospital are these other ones: the inclusion of extended-release buprenorphine, IOT, and this ED induction appendix. So I'll talk about these one at a time. So just a quick review: the inclusion of extended-release buprenorphine, also known as Sublocade, is new in these guidelines. And that is because in 2017, it was not on the market in Canada. So it's only come to market in Canada since 2019. But it is an available evidence-based treatment for opioid use disorder that's been available in Canada since that time. So as per the product monograph, our guidelines now suggest consideration for anyone who's stable on 8 to 24 milligrams of sublingual buprenorphine. And similarly, IOT, so injectable opioid agonist treatment with diacetylmorphine, aka heroin or hydromorphone. In 2017, there was separate guidance around IOT. It was still a type of program that was getting off the ground. And in 2023, we've incorporated that into our clinical guidance as a whole, recognizing that that this is a part of the continuum of care and it's not an asterisk. It's not something that needs to be kept separate. So extended release buprenorphine, many of you will have come across this. This has been, it's been 4 years now since we've been prescribing it. So this is not new, but I want to talk about it because it's in the guidelines now for the first time. And because I think this has a lot of relevance to us in hospital for a few different reasons. So this is the recommendation. So again, patients who are stable on 8 to 24 milligrams of buprenorphine may be offered the extended release formulation if indicated by patient preference or circumstances. That's a low evidence. The strength of evidence here, it's this is a new product, but a strong recommendation. For those of you who have not seen extended release buprenorphine or Sublocade, this is not exactly what it looks like, but you know what I mean. So it's a subcutaneous injection. It's an abdominal injection that's rotated through the 4 quadrants of the abdomen. Patients come in once every 4 to 6 weeks to receive their injection. The volume is either 1.5 mils or 0.5 mils, depending on the dose. They inject this gel. It's called Atrogel. Is the compound which it's embedded in. It hardens up into a ball, into a subcutaneous nodule, and it elutes the medication slowly over time. You can feel it. If somebody's skinny, you can see it. Recently, one of the emergent docs at Lionsgate called me because they were worried about an abscess, and I told them they were just ultrasounding the nodule. They were trying to stick a needle in, and they couldn't get it in. He was asking me what's going on. It's the nodule. You can see it on ultrasound. Not surprising. This is just a graph depicting serum levels of buprenorphine. So not surprisingly, it gives you very sustained, steady levels of buprenorphine over time, much more so than the peaks and troughs you get with once daily sublingual dosing. It's a wonderful product for people for those who it works for. The goal in including this in the guidelines was clearly just to increase access and provider comfort as well with providing new forms of evidence-based treatment for opioid use disorder. But why does this have particular relevance for us in hospital? For a couple of reasons. So just as far as the evidence going behind it, this is sort of the landmark Sublocade paper, is a 2019 Lancet paper, which showed it showed here that the purple and the red are the maintenance doses of either 300 or 100 milligrams of Sublocade in terms of absence compared to placebo. How you get away with doing a placebo-controlled trial in 2019 for the treatment of opioid use disorder when we have gold standard treatments available to us? It's a great question, but this is what they did, and this is what they managed to publish in the Lancet. So you can see, not surprisingly, it's much more effective than placebo. Which is not a shocker. As per this data, there's no difference between the 300 and 100 milligram maintenance dose, which is why you'll often hear us talk about having people on the 100 milligram maintenance dose. There's a lot more to it than that, which I won't get into today. There's reasons why you might do one or the other, but it's a pretty effective medication for those who it works for. Little asterisk here. This is all done in the pre-fentanyl era. But why is it of relevance to us? Well, not to get into the physiology of buprenorphine too much, you guys are all at least probably hopefully a little bit familiar with it, but it is a partial agonist at the mu opioid receptor. It is not a full agonist. So there's a ceiling effect to buprenorphine. It kind of tops out at a certain dose. It is also a very high affinity, probably the highest affinity opioid that we have out there that we at least use routinely. In essence, that means it almost operates as a partial antagonist because it will saturate and outcompete other opioids, which is why it's sometimes great, but sometimes a tricky little molecule. There's lots of implications for that, but for the purposes of those of you who are not actually prescribing it, the one that I'll make you aware of is highlighted by this paper. This is a bit of a gratuitous reference. This is a small paper that I just want to show this because this is quite a wild paper. This is a small paper that was done in the Netherlands and the US that actually gave people buprenorphine infusions and then gave healthy volunteers serial doses of increasing fentanyl and watched for respiratory depression, which is pretty gnarly. So I just wanted to put it in there because it's kind of it's interesting. This is a small paper, but it highlights what I'm talking about. That is the effect that buprenorphine has in blocking other opioids. So what you see here down the middle, the placebo dose, that's those who received a buprenorphine or a placebo infusion, and then were given these serial doses of fentanyl, so 250 mics, 350 mics, 500 mics, and 700 mics. The number there is how many out of the numerator is how many people ended up needing verbal stimulation to kind of wake them up a little bit versus the denominator who actually volunteered to receive that dose. So in the placebo, 0 out of 8 people, everyone was fine with the 250 microgram dose. With 350 milligrams, 2 out of 8 people needed like a, hey, wake up. Some of them did not receive the 500. So 1 out of 6 received the 500 mic dose, needed a little bit of verbal stimulation. And 3 out of 4 who went for a 700 microgram dose of fentanyl needed some verbal stimulation to wake up. Contrast with those same volunteers after they received a buprenorphine infusion, and all the way through 0 out of 8 of them needed any verbal stimulation to wake up. So again, I don't really need to show this reference. It's just kind of an interesting study that grabbed me, but it does depict pretty visually the effect that buprenorphine has of blocking other opioids and that and the partial agonist effect of the bupe itself.
I know there's probably not a comparable study, but how does that compare to the synthetic fentanyls that are actually?
How does their fentanyl compare?
Just in terms of the competition for the finder.
I mean, who knows what's in any given, there is no comparable study. Fentanyl, I don't know what the comparative affinity for the mu-opioid receptor is amongst all of the fentanyl derivatives. Fentanyl is a rather high affinity opioid itself. So you could expect that versus morphine or methadone, for instance, this would be a more dramatic effect. With a variety of fentanyls, they're going to have the ability to break through a little bit more easy. And it's going to be a dose dependent thing as well. I would never, ever, ever market buprenorphine as like significant protection against overdose. I'm not going to tell anyone this is going to keep you from overdosing. It does offer some overdose protection, but I don't want to sell it as such because you can definitely break through with enough or a high affinity opioid.
So what was the duration? When did the verbal stimulation was what?
So they infused them with placebo or bupe. They gave them a bolus dose of fentanyl, and then they watched them for I'm not sure how many minutes afterwards to see if they essentially needed some verbal prompting to wake up immediately following receiving the fentanyl dose. Like actually 15 minutes probably. It was an IV infusion, so rather quick. I don't know what the timing was. But again, it illustrates the blocking effect of bupe, which I think is important because for those of you who are working either in the emerge here or perhaps in a peri-op clinic, watch very carefully for entries like this on Pharmanet, because it can be tucked way back there. So this is given once every 4 to 6 weeks. So if somebody's on a heavy medication load, it would be very easy to miss this. Hopefully somebody's telling you about it, or you're finding multiple nodules in your physical exam. But it'd be very important to know in an acute admission, in a trauma, in a peri-op patient, if they're not volunteering that they're on Sublocade, you probably want to know that because this has enormous relevance to your strategies for withdrawal management, but more like analgesia itself in hospital. So if you do see one of these on there, consider using multimodal analgesia, non-opioid adjuncts, local blocks, involve anesthesia, lead anesthesia, no. Use opioids with a higher affinity for the mu-opioid receptor, i.e. fentanyl. You could use fentanyl or Sufent rather than things like morphine. Hydromorphone also rather high affinity. And expect a probable need for higher doses of opioids than what you anticipate because not all of it's actually able to act at the mu-opioid receptor itself. The other piece to this to remember is this is not just the last 4 weeks. You may have to go back even further to see whether this is on their med rec or not, because these little nodules that we're injecting subcutaneously, they don't completely dissipate after 4 weeks. So the recommended interval for doses is every 4 to 6 weeks. This is modeling data. So this is not actually physiologic data, but this is modeling data estimating how long it takes somebody to go from a maintenance dose of these medications to a subtherapeutic dose if you were to discontinue. The 100 milligram maintenance doses at the top, you can see that this is just an axis of time versus concentration. And you can see that last peak in blue of the last time of administration at 32 weeks between when it drops below 2 nanograms per ml, which is kind of the not totally arbitrary therapeutic dose, is about 8 weeks to get to a subtherapeutic dose, and much longer than that to get to an undetectable dose. If somebody's maintained on the higher dose and you stop, we're looking at 20 weeks before they drop down below that 2 nanogram per ml dose, even longer before this gets subtherapeutic. So somebody could, I've seen people have this in their urine easily 8 months after the last dose. How much physiologic relevance it's having at those doses, how much that's actually blocking, very hard to say, probably a lot of variability there, but it lasts longer than you think it does. And so be very cognizant that if somebody is 2 months out from the last dose, you have to operate according to the same principles. So this, I think, has a lot of relevance to us in hospital, just bearing in mind how long this stuff kicks around for. So that's all I was going to say about Sublocade or extended release hydromorphone. Again, the inclusion of diacetylmorphine and hydromorphone here is not new, but it's combining a previous sort of satellite guideline with the full update itself. Just recognizing that IOT is a part of the continuum of care for people with opioid use disorder, and it should be considered for adults with severe opioid use disorder and ongoing unregulated injection, IV use, who have not benefited or who are declining all other oral options. This was the previous IOT guideline, the standalone guideline, and that's just being incorporated into our new guidance. Just recognizing IOT as a part of the continuum of care and acknowledging that the evidence supporting its effectiveness at reducing use of illicit substances, decreasing criminal activity, reducing mortality, increasing retention, and improving quality of life is substantial. So again, just about making sure that patients are provided with the breadth of options depending on their goals and preferences and circumstances. What is the relevance of this in hospital? Well, you may have seen that in the last year and a half now, we actually have IOT or diacetylmorphine on our formulary here. We're seeing lots more doses of IV hydromorphone, which is being, I guess I would say, necessitated by that increasing potency of the drug supply, and more diacetylmorphine. Really, probably the most relevance for this group is just recognizing what is diacetylmorphine. It's not a classic opioid that we're learning about in residency in terms of its potency. It is very analogous to hydromorphone in terms of its pharmacokinetic profile. Its potency, which is highlighted here, it's essentially 2 to 1 with hydromorphone. So if somebody's on 10 milligrams of hydromorphone, that would be roughly equivalent to 20 milligrams of diacetylmorphine, and they're quite comparable in a lot of ways. So that's just a conversion that, especially at St. Paul's, may be of use to everyone here. You'll see less of this. I don't know any other hospitals in the country that have this on formulary, but it is used in the community. If you ever end up admitting somebody from an IO program and you need a sense of what their opioid needs might be to meet their baseline needs, this would be the equivalence. Last addition that I'll highlight here is this appendix, one of many appendices, but one that I really want to highlight around induction with buprenorphine in the emergency room. It's building off of a lot of evidence, primarily in the US and Canada, about the efficacy of starting bup in the emerge in terms of linking people to care. But really, this is just copied directly from a guidelines. This is a standalone statement that I think speaks for itself. Over half of the over 10,000 people who had a fatal or non-fatal overdose in BC from 2015 to 2016 had utilized ED services in the past year. So over half of the people that died over that time had touched the medical system. In 2017, 70% of people who died from drug toxicity in VCH had touched the medical system in the last year. So we're failing to engage this population or to keep them safe. Whatever we're doing is not working if that many people are coming into contact with the healthcare system and they're still dying. This is a paper by some colleagues of ours in Boston that is one of the most, I think this maybe it was just the time in my life when this came out, but it's one of the most meaningful research studies that I've ever read in terms of the way it resonated with me. This was looking at a retrospective cohort, a linked cohort in Massachusetts. So different context, but for what it's worth. And this was looking at after people presented to hospital with a non-fatal overdose, what was the rate of receipt of medications that for opioid use disorder that they would receive, and what was the association with mortality? See, the adjusted hazard ratio for reduction in all-cause mortality in the 12 months following presentation for non-fatal OD for methadone was 0.47 and for bup was 0.63. And I defy you to find a medication that we use in internal medicine that has that impact on preventing all-cause mortality in a young population. Those are, again, that's a testament to how well these medications can work if we get them to the right people at the right time. And yet, of all of those who presented with a non-fatal overdose over 12 months, only 30% of them ever received a script, and many didn't stay on it. So 70% of people who showed up at a hospital having had a non-fatal overdose didn't actually even fill a script for the gold standard medication for treating the life-saving medication for treating that condition. So that speaks to me as an internist, as just something that, like, an area that we need to do better at. And the goal in including this appendix was just to encourage outstarts whenever or wherever possible. I'll build off of that and say, we have a breadth of people from a breadth of backgrounds here who work in a breadth of different settings, but all of you who are in internal medicine or in emergency medicine, or really who are working in a hospital anywhere, please, please, please think about this and consider making sure that you have the skill set to start this medication, because this is the number one way that you are likely to save a life if you're prescribing this medication when that opportunity presents itself. A number one. I don't want to rank them, but so in summary, the 2017 BC opioid use disorder guidelines were a landmark document. Much has changed since then. The new guidelines combine updated evidence review with a fairly substantial increase in clinical experience operating in this new context to try and improve access, retention, and quality of care for people with OUD. I didn't even get into this, but there's some really interesting evaluation strategies in place around monitoring the kind of uptake and role and impact of these guidelines, because we do have the ability to monitor these medications quite closely with linked administrative data. Some of the key changes do include an adjustment to medication selection, dosing strategies, and increased access to take-home doses. And the new additions that I've highlighted here that I think are particularly relevant to those of us who work primarily in acute care include the inclusion of extended-release buprenorphine, IOT, and that guidance on ED-based bup inductions. I am going to take an opportunity to highlight this line. Again, for those of you who work at St. Paul's, you have us at AMCT available pretty much all the time, and I hope you use this as a resource. But for anyone working elsewhere who doesn't have access to a consult team, who's in the community, or where it's after hours, this is a 24/7 addiction medicine support line for the province. You can call any time of day, any day of the year, and speak with an addiction physician for advice. So please take advantage of this if you're out in rural rotations or if you're working anywhere other than this hospital. And I'll just acknowledge again my co-chairs, Rupi Bar and Emma Garrett. This has been 4 years of work, postponed by COVID. I don't want to sound too dramatic. Two of those years were rather a slow burn because of other things, but 2 years of pretty heavy work with Emma and Rupi. The writing team, particularly Miriam, has been amazing. Again, she wrote most of this 220-page document, so deserves a ton of credit for it. All of our authors and contributors and reviewers and everyone who participated, some of whom work in this hospital, I'm very thankful for their contribution, and all of those who've lost their lives. And with that, I am happy to take questions.
Maybe see if there's anybody on that. Is there anybody online that would like to ask Dr. Bach questions? Hearing none, how about from the audience? Any questions?
Will there be a separate guideline for more safe supply?
So I was very deliberately not included in this because for those of you who are aware, there's a very active conversation in much of Canada around hydromorphone, prescribed safe supply, safer supply, whatever you want to call it, or access to a form of regulated drug supply, which I think is a really complicated and important conversation. But very clearly, to me at least, and to the committee, is quite distinct from treatment of opioid use disorder as we conventionally view it. And so we very deliberately wanted to focus this on evidence-based treatment for opioid use disorder according to the established standards in North America. That is a very separate discussion. There will be many new conversations, media pieces. There's a number of documents that will be coming out from the provincial government in the next few months, speaking to various aspects of the program in BC and elsewhere. I fully expect that we'll be tasked to produce more clinical guidance in that area, and we'll see how that goes. But it's a separate discussion, and one that we could talk about for a long time.
Yes.
Thank you so much for the summary and for all your work on this. I was wondering when the government, in a took back the looser regulations around take homes for methadone. How do we see that impact the overdose rates?
So that's a really great question, and I don't have an answer for you because the way that this is played out has been very different in very different settings, both in terms of different provinces or states with different guidance, as well as even at different clinic levels. So that guidance came out at least in BC, Ontario, quite promptly after COVID. Many provinces just sort of follow our guidelines, either openly or less openly. So I don't know what the role in other provinces is like. SAMHSA is the don't make me remember. The SAMHSA is the body that kind of governs clinical guidance for the entire US and the US, and their guidance was quite loose in that they'd say basically take home doses for up to 4 weeks for anyone at the clinician discretion. So when the reversion, like kind of reversion to the mean, has happened both through policy changes as well as just sort of like practice patterns reverting back to the mean as we've come through whatever COVID's over, right? So like in Ontario, for instance, much of the practice patterns have just sort of reverted to the mean without any actual guidance itself. It just sort of happened that way. In the US, we felt very brave, I'll say, putting this guideline out around take-home doses because there has been such it's been the way things are for so long. And so there was many meetings and much review of the evidence, a lot of collaboration and we settled on this paradigm, and we are very nervously excited about it. And then since this was finalized as being in the review process, SAMHSA in the US basically said, keep going. This is the rule now. Anyone can do take-home doses up to 20 days, 28 days for anyone you want, whenever. So they've actually kind of superseded us with a much more loose prescribing recommendation. But that is their guidance, but every state then has input on it, and every different the way that methadone is prescribed in the US is different. You don't pick it up from a pharmacy like you do here. It's like methadone clinics, so their own procedures and policies vary too. So there are many different patterns. That's a long-winded way of saying I don't know, and because everyone's kind of gone in different directions. But certainly we have seen a reversion to the mean in the data in Ontario at the very least.
But Paxton, following up on that,
Yeah.
since changing the guidelines, is there a way of, do you follow patients that are doing this differently? Is there a registry?
Yes, so I've highlighted a few of the papers here. So we're working on a collaboration. Actually, this is something that I'm quite interested in. We're working on a collaboration with a epidemiologist, or actually a health economist from SFU named Bodan Nosek, who I've highlighted a couple of his papers there. He's brilliant. And he has a linked administrative database for our province that links hospital admissions, EMS calls, and all prescribing of these medications through PharmaNet. So we can track every dispense of these medications in the province for the past 3 decades and link that to all these other databases. And because methadone is prescribed in such a restricted fashion where you contact pharmacies so often to pick it up, we have remarkable clarity on exactly who's getting doses, exactly what that dose is, who prescribed it, when they picked it up. There is no database anywhere in the world that is actually more suited to answer that question than ours. So we have a unique opportunity to really track who is prescribing these, how does this play out, who is accessing it, and what are their impacts on things like retention and overdose death, or non-fatal overdose, presentations to care, all of those things. We can look at all of that. So a lot of really interesting questions we can ask here. And then the corollary of that will be overdose deaths. Is there a risk about this entering the drug supply elsewhere? And we can answer that looking at toxicology from overdose deaths as well. Yes. So this just started. This came out 2 weeks ago. But yeah, there's a collaboration being developed with this particular fellow at SFU to do exactly that, because I think there's a unique opportunity to with these guidelines and with that granularity of data to look at outcomes and to even look at rollout. We can look at who is prescribing these things. What does the KT look like? Is it addiction specialists? Is it family doctors? Is it urban or rural? Is it people working in group settings or individual settings? So we can actually in real time track the rollout of these guidelines as to how it's actually being taken up in the province. So a lot of really cool evaluation work to come.
Any other? Yes, please.
So I think this really highlights the really exciting progress and momentum that the pharmacotherapy has certainly need. But we know that the retention rates are so low. I think you said 16 after a year, which everyone's working on. But I'm wondering, are we seeing a similar momentum and improvement of the psychosocial treatment for opioid use disorder as well? Because I do struggle to see how a significant portion of patients can be holistically treated when the focus really is on the pharmacologic treatment. For so many, it's either not enough, it's not what they need. Like, what about the vocational skills training? All those things that we think about, but do we see that momentum too?
Sort of. Yeah, so sort of. I mean, it's a great question because OAT is, certainly the gold standard medical treatment for opioid use disorder and incredibly effective at what it does, but it does not do justice to the complexity of an opioid use disorder and all the reasons that people use opioids and all the things that people need, to support them in their goals. I mean, I could talk about this for. I guess what I will highlight amongst the many things is, the data. Making guidelines and recommendations that is really hard because, as you may be aware, the data is really heterogeneous because everyone's doing different things in different places. There's not a lot of standardization. There's not a lot of transparency. It's very hard to say what is best practices in this area according to the data, which speaks to a real need to actually do more of that work to standardize and evaluate and really develop best practices and then hold people to that, because there's not a lot of that in the recovery industry in much of North America. But what I can say to your question more directly, and this is not to be too self-promoting, but what we are trying to do here with the launch of our new ward that you may have heard of, the Road to Recovery Ward here, it's not about just the ward itself, which is where we started and which is a valuable addition to the resources, but it's about building a system of care that's co-localized under one roof that actually takes patients through it in a seamless way. I don't know if you've ever had to navigate our treatment system for a patient or a friend or family member, but it is not easy to do. It is a lot of really good people doing a lot of really good work in a lot of places with not a lot of standardization or coordination or fluidity. It's not much of a system. And so the idea behind what we're trying to do with this new program at St. Paul's, thanks to some pretty generous philanthropic donations, is to build a system of care that speaks to all of those aspects of somebody's opioid use disorder and carries them through the system in a fluid way where they don't actually have to do all of the work every single step of the way. That will be important for our patients here. I think it's there's a very, very thorough evaluation process looking at the effects of this program itself, which I think it's hard to imagine that it won't be positive because it's such a important contrast to the way that things are being done. But the proof of principle there and the potential scalability both across BC as well as elsewhere is what really excites me, because you're right. Everyone, every individual has a different relationship with substances and a different reality and different needs, and those change. And so to try and distill this down to just prescribing a medication being done with it is obviously insufficient, but it's going to take a lot of time to build up a treatment system that actually supports people in all their areas of need. And even beyond that, the emphasis on social determinants of health is still not a significant enough part of the conversation with respect to the overdose crisis as it needs to be. We still don't hear people talk about the fact that homelessness in Vancouver has increased 30% in the last 2 years. And that's a problem. That's directly correlated to the rates to the record number of overdose deaths that we had in November. That's a long-winded answer to your question, but it's a very good question.
Any other comments or questions? If not, thank you very much.
Hey, yeah, I think we met one of the wards recently, Paxton.
There's a focus on talking about mortality as kind of a key indicator, and then you reference this evaluation framework.
Which one's that? The evaluation framework for what we're doing here?
Yeah, I mean,
No,
I think it'd be nice to know. Everybody, I'm relatively new.
Yeah.
Everybody talks about the epidemic getting worse. I think just anecdotally through their own experiences. But is there any data that's published on rates of use?
Rates of use is really hard, right? Because we have there.
If
If I was to point you at least specific author in our province, it'd be Bodan, who's done a lot of work talking about modeling the amount of people who are opioid use disorder, the amount of people who use opioids or other substances who are at risk of overdose who don't meet diagnosed criteria for use disorder, the cascade of care, like who do we think's out there, who are we touching, who has engaged in treatment, who's currently engaged in treatment. He's got a lot of really good BC data around some of those things in terms of some crude numbers. But it's bigger than that, but Bodan's got some really good work that kind of starts to depict the scale.
Do we even know like how many people are part of the downtown east side?
Yeah. So yeah, well, I mean, I guess it depends what you mean by part of. But yeah, we know how many people reside in the downtown east side. We have a sense of like percentage of substance use disorders and mental health diagnoses in that population. We have a homeless count for the Lower Mainland, but what I would point out is that while the death rate per capita is highest in the downtown east side, the vast majority of deaths in this province are not in the downtown east side. They're actually outside the Lower Mainland.
I mean, it's pretty
and they're usually in private residences.
Heterogeneous.
And they're usually smoked opioids. It's not in homeless injection drug users.
I have to say, I never see injection. People aren't declaring it, and I'm not seeing evidence on exam of like a lot of injection drug use of patients here.
I mean, here most people. Well, you can ask them. Like it's pretty. It's more just the way people use drugs changes over time, and there's lots of geographic variability. So like in Ontario, for instance, smoking is much more common. Here in Vancouver specifically, we still have a pretty significant amount of people inject at least sometimes. If they have veins that are left. So depending on kind of what population you're looking at, we're probably like a lot of our patients here do have a history of injection drug use, even if it's not their exclusive route of use. But the majority of overdose deaths in the province, people smoke their drugs in a private residence.
Yeah, I mean, it just. I'm sorry.
Don't
run any question. Of course, mortality is important, but you want to feel like less people are using opioids, right?
A number of people who've been using opioids we can model and has probably increased a little bit over the past 20 years, but hasn't changed that dramatically. It hasn't. It's not about the number of people using. It is 100% about the drug supply itself and the danger of using that drug supply.
Okay, that's interesting. Because when people say, as a new person, the problem is getting worse, they're not talking about mortality.
They're talking about visible poverty. They're talking about mortality. Mortality is getting worse, right?
No,
but they're talking about visible poverty and mental health issues. Like not to minimize. So if you look at the homeless count that came out this year versus 2 years ago, there's been about 1,500 more homeless people in the Lower Mainland than there was 2 years ago, or about 5,000 in the Lower Mainland, which is a lot. And the amount of mental illness that we're seeing amongst the homeless populations is soaring, probably due to like pressures of living on the street, but also due to rising crystal meth use. The crystal meth has 10 years ago, you'd see very little crystal meth here, and now it is by far the dominant stimulant drug supply, and often used by people who use fentanyl. They use them together to kind of offset the effects. So it's complicated, and it's not due to the drugs, but it's also not exclusively due to the drugs.
Yeah,
you're seeing like a societal breakdown happening, and we're just
is it so? All the public uses of drugs that's just more people using, or
I think it's more attention to it. Like people have always used. People have always used drugs. Like the number of people using drugs has not changed dramatically in the province. I'm not sure what the population of the downtown east side has changed, but the homeless population of the downtown east side has increased dramatically. So there's more people out there using. Has public drug use increased since decriminalization? There's no metric that suggests that's the case. People say it's true. I don't really think it's true. I think we're just more conscious of when we talk about it more, and perhaps they're using more outside of like their confined areas. Whether that's because of decrim may play a role in that, or whether it's because we just tore out all the encampments and people don't have like places to congregate and use. That's probably a big part of it as well. Like the problem is getting worse, but it is not. The drugs are as much a symptom of the problem as they are a cause.
It's not. It's the same percentage of that population is not growing either.
And a fairly significant the population of homeless people who are using is a fairly significant proportion of those who are dying don't actually have a use disorder. They're just some people who use drugs sometimes.
Actually, that was a really good
Great,
discussion.
thank you so much.
Yeah, you bet.
It wasn't the question that I had in mind, but
Yeah.
like it's something I think about in the background. Anyway, I'm Leo, and I just
Hey.
had one more question. I was just wondering if this is something that I think might come with clinical experience, but like some of the patients that have been discharging, like they have like a very fixed, what I've seen so far is that they have a fixed supply of say, for example, Canadian. And my question is like, when I'm not too sure, I guess like the patients like familiar with their primary care provider and they're kind of like code naive. I was wondering, like, I don't know if you had any general guidance or like when it came to follow up with how they're going to be doing in the community, like I guess your threshold for kind of a RAC referral.
RAC referral is always there. We're a safety net for anyone. We don't, if somebody shows up at the RAC and they have a provider in the community, we share an EMR with much of the community. So if somebody shows up and they're followed at, the Pender Clinic or something like that, we'll direct them to their clinic. So we have a primary care clinic who knows them. But I tell everyone up at the RAC every time I see them, even if they are followed elsewhere, to say, if you know anyone who needs to see somebody, come to the RAC. If you're trying to get in your clinic and it's closed, come to the RAC. If it's a weekend or a holiday, come to the RAC. It's a safety net. You can always send people there. Because there's lots of people out there and there's lots of people there who have had a provider in the past, been some time, and whether or not